Premature ventricular contractions. We're going to define premature ventricular contractions, or PVCs. We're going to list the diagnostic criteria for a PVC. We're going to differentiate between unifocal and multifocal PVCs. And then we're going to be able to identify a PVC on a rhythm strip or the ECG monitor. So premature ventricular contractions are a very common occurrence and can occur in the normal population as well as in patients with cardiac disease. In any one patient, the number of PVCs that occur can vary tremendously based on the time of day, types of medications, coffee, soda. There's 100 different variables that could cause PVCs. They usually cause no symptoms, and the patient will be completely unaware that they're occurring. Other times, a patient may feel just a slight skipping in the heart or a sense of palpitations. In some cases, however, the unsynchronized contraction of the heart caused by PVC may actually lead to a momentary stop in cardiac ejection fraction, thus resulting in a hemodynamically compromised patient. So, what are some of the things that we're going to look for with a PVC? Well, it's going to be a premature contraction, meaning that it's going to occur before our next expected underlying complex. It also originates in a ventricular ectopic focus, so because of that, we can expect it to be wider than 0.12 seconds and have that bizarre morphology. We'll also note ST segment and T wave abnormalities because of the time it takes to repolarize as well. And it's usually associated with compensatory pauses, but non-compensatory pauses can occur as well. So when we're identifying premature ventricular complexes, we need to remember that PVCs will always have an underlying rhythm. And so we've got to identify the underlying rhythm first. So these are actually going to be individual complexes rather than an actual rhythm. Now, it occurs unexpectedly or before the next expected beat. So this is showing an example of multifocal PVCs, which means that they originate in different ectopic areas. So the third beat and then that beat. And again, they look different in morphology, so that means that they originated in different areas. So this illustrates a PVC that occurs in the midst of a sinus rhythm. So our underlying rhythm is a sinus rhythm, and it is obviously premature and has a wide and bizarre appearance. Just like premature junctional complexes, PVCs can have fixed or non-fixed coupling intervals. And so again, the coupling interval is the distance from the previous QRS complex to the PVC. So again, we're looking at the distance. And if it occurs in a pattern, then this is a fixed coupling interval. It's a pretty common occurrence when they originate in the same ectopic foci, so we notice that they're the same because they're of the same morphology. And fixed coupling intervals should not be off by more than 0.08 seconds. You can also have variable coupling intervals, and they're more common in PVCs that originate in multiple ectopic pacemakers. So if a fixed, we have the same coupling interval, a variable is going to be different between the PVC and the last underlying beat. Also, we need to discuss R-on-T PVCs. A PVC typically occur after the previous complex has finished repolarization, which this means it's going to be after the T wave, so typically you'll see the PVC there. But what happens if the PVC starts during the relative refractory period? And this is why we needed to understand the difference in absolute and relative refractory period. And if you still don't, you need to stop the video right now and go back and review the relative and the absolute refractory periods. But in certain cases, the PVC starts during the relative refractory period of the previous complex's T wave. And this can create a potential for serious re-entry loops and circular movements within the ventricles, which can lead to life-threatening arrhythmias, including ventricular tachycardias. And if you note the R on T, and how do I know this R on T? Well, I note that I've got an underlying T wave in the rest of my complexes, but I've got this PVC right here that is occurring on top of this complex. And so if that happens, I need to continually monitor my patient for serious arrhythmias. Another concept to talk about is an end-diastolic PVC, which occurs when a PVC falls in such a way that it falls after the next normally occurring sinus P wave. End-diastolic PVCs are common when the underlying rhythm is a sinus bradycardia. So if you notice, my P to P interval is constant across the board. But what happened? Well, I lost my normal QRS complex here, but my P still fired. So this is called an end-diastolic PVC. This is an uncommon occurrence. And this is talking about the concept of the compensatory and non-compensatory pause. And this is something that we've talked about with all of our premature complexes in the previous lectures as well. But the ectopic ventricular depolarization wave does not retrogradally spread to the atria. And in this case, the sinus node is not reset, so it continues to beat in its fashion. So if I were to measure my next R to R, it's going to be the same as this R to R right here. Now, a non-compensatory pause, this occurs when you have a retrogradally spread depolarization wave from the AV node back up to the ventricles, and it causes a reset of the SA node. And then in that case, it actually interrupts the underlying R to R. And so now, once I see my next R to R, I'll see that it's different between the first one. Unifocal PVCs means that they all come from the same area of ectopic foci. Unifocal PVCs will have the same coupling interval throughout the rhythm strip. They'll all look very similar, very uniform. In this case, you can tell that each one of these PVCs is coming from the same factory, and that factory is putting out the exact same product. Multifocal PVCs originate from either different ectopic pacemakers or in the same ectopic pacemaker but take different routes to depolarize the ventricles. So this is just showing all the different areas that each one of these could come from. So essentially, they're coming from different factories, and so each factory is producing its own product, or they're coming from the same factory, but they're taking a different route to get to where they're going. And recurrent PVCs can follow a specific pattern. So these are terms that we should already be familiar with, but you've got ventricular bigeminy, trigeminy, and quadgeminy. So bigeminy occurs when every other beat is a PVC. Trigeminy when every third beat is a PVC. Quadgeminy occurs when every fourth beat is a PVC. You can have couplet or repetitive PVCs, and that's two PVCs occurring together without a normal complex in between. Or you can have runs of VTAC where you have three or more PVCs in a row. So triplets, when three PVCs occur sequentially, they're also known as a triplet, and this could also be known as a run of VTAC, or some terminology uses the term salvos. And salvos refers to a group of three or more ectopic ventricular complexes occurring sequentially. You can also have fusion of various ventricular complexes and their associated waves. This is a very common occurrence when you have more than one occurring PVC. You can also have the concept of multifocal triplets. So this is actually three different ectopic origin PVCs that have occurred one right after another. The different appearance of the 3 ventricular beats and the varying degree of fusion between the waves gives us a really weird, bizarre looking appearance. So the concept of an interpolated premature ventricular contraction, we're going to note that the underlying sinus rate and complexes are completely undisturbed. So this PVC has occurred exactly in between 2 complexes without any interruption in the underlying rhythm. This can occur only if there's no ventricular atrial activation from the premature ventricular contraction. So remember again, you've got to always identify your underlying rhythm, and that's where we're going to get our rate from. It's going to be occasionally irregular because our disruption in our R to R intervals. The P waves, it's all going to depend on our underlying rhythm. The length of the PRI is not going to be present with PVCs, but we will have a PRI with our underlying rhythm. And the QRS is usually going to be wide and bizarre for our PVCs. For our underlying rhythm, it just depends. Usually it's going to be 0.12 seconds or less. So this is an example of a unifocal PVC. So we've got a sinus rhythm with ST elevation and unifocal PVCs. This is multifocal. So we've got a sinus rhythm with multifocal PVCs. We don't have enough of a strip to determine is it a bigeminy, trigeminy, or quadgeminy. But we do have enough to determine that these come from different ectopic foci. So it can be idiopathic and benign in origination. Anxiety can cause it, fatigue, certain drugs, hypertrophy, cardiomyopathies, also heart disease, and electrolyte disorders. And like I said previously, they could be benign or they could cause issues. So our clinical significance, little or no significance in patients without history of heart disease, may even relate to their intake of caffeine or other stimulants. Cardiac output may be compromised if PVCs are frequent, and in some cases, administration of oxygen may abate the PVCs as well. So looking at a couple of examples. In this rhythm, my rate, because I'm counting my PVC, is around 100. It is irregular because I've got a disruption in my R to Rs. My P wave is normal for my underlying rhythm. My PRI for my underlying rhythm is 0.18 seconds, and my QRS is, for my underlying rhythm, is 0.08 seconds. Now my PVC is wide and bizarre. So what's my interpretation of this rhythm? Is going to be sinus rhythm with a PVC. This rate is around 100 or maybe a little greater. It's going to be irregular because I've got a disruption in my R to R. It actually would have a regular pattern here if that PVC created a pulse at the same time that the other contractions did. P wave for my underlying is normal. My PRI for my underlying is 0.16 seconds. My QRS is 0.08 seconds. And this is a sinus rhythm or a sinus tach with a unifocal PVC, and it has a full compensatory pause. This is going to be a sinus rhythm with unifocal PVCs, and in this case we have non-compensatory pause, and if you will see that the underlying cadence starts over with each PVC. If you notice, there's a P wave occurring before the PVC right here, so this is actually a sinus rhythm with an end diastolic PVC. My rate is 90. My rhythm is actually regular. P wave for my underlying is normal. PRI for my underlying is 0.18 seconds. and my QRS is 0.10 seconds for my underlying. Now, what do I notice? I've got unifocal PVCs, meaning that they all look the same, and they're occurring after every other beat. So I have an underlying complex and a PVC, an underlying complex PVC, underlying complex PVC. So this is a sinus rhythm with unifocal PVCs by Gemini. Now these blue waves, or these blue arrows right here, are pointing to something that may be a pseudo S wave, or it may just be part of the S wave itself, but the pseudo S wave may indicate a P wave that's retrogradely conducted, but that doesn't necessarily matter when we're trying to initially identify these. So my rate's around 70, it's regularly irregular, and it's my P wave's present and normal in everything except the PVCs. My PRI is 0.16 seconds, and my QRS is 0.08. And in this case, we've got a PVC every third beat. And so this indicates a sinus rhythm with PVC's trigeminy, or you could call it ventricular trigeminy. This is going to be sinus rhythm with ventricular quadgeminy, or sinus rhythm with PVCs, they're unifocal, quadgeminy. Now notice this right here. We've got two back-to-back PVCs that are unifocal in nature, but they occur one right after another. So I've got an underlying rate of 1, 2, 3, 4, 5, 6, a little less than 60 is irregular because we've got a disruption in the R to R's. My underlying PRI is 0.18 seconds and my QRS is 0.08 seconds. So my clinical diagnosis of this would be a sinus bradycardia with unifocal couplet PVCs. In this one, this is a sinus rhythm that's undisturbed by the extra events. So it's undisturbed. The underlying rhythm is undisturbed, occurring in the ventricles. The pauses are fully compensatory, and the P waves show through and fuse with the morphology of the PVCs at the start of the complexes. The underlying ventricular depolarization during the sinus complexes demonstrate a varying degree of aberrancy in ventricular conduction. So we will identify the couplet here. So this is going to be a sinus rhythm with a unifocal couplet and one unifocal PVC. And our last rhythm, this is going to be multifocal. If you notice, I've got different morphologies of all my PVCs, and they're occurring pretty frequently. So this is going to be a sinus rhythm with frequent multifocal PVCs.